Thank you so much for being here, everyone. Dr. Chadamambe and I are extremely excited to have everyone. We love this topic, her and I, and we have been slowly working together over the past maybe 2 years or so on a lot of different patient cases, and it's just we have such a wonderful opportunity to have her here today, so I very much appreciate that. So I'm Erin Falco. I'm the owner of Root Health Nutrition and Wellness, the practice that you are here today. And my area is nutritional psychiatry. So how do nutrients affect our brain? I've been a dietitian for about 13 years now, and over the last maybe 6 or 7 years, I dove into functional and integrated nutrition. So my training has been undergrad in nutrition, and then I did my clinical rotations in the hospital. And then after that, I did a fellowship in nutritional psychiatry and integrated nutrition. So here I am today. I worked mostly with pediatrics, and I do still see some adults that I've been seeing over the years, but my area is the gut and the brain. So that's what we're going to be talking about today. And again, I appreciate you all being here.
Awesome.
Yeah.
Yes, thank you so much, Erin. I feel so honored to be here and certainly honored to see all of you. I am a pediatric neurologist that has slowly but surely become more psychiatry in all our practice because of my interest and passion for children, specifically with autism spectrum disorder. I am at Neurabilities as their chief medical officer, and just love the opportunity to work with a lot of kids that specifically have autism. I also work with adults, so not just children. I do work with adults as well. And it has been a pleasure working with Erin. I feel like I know nothing about the gut. It comes up every single time. So it's really wonderful to have somebody I can, refer my patients to and work with collaboratively. So this is really an honor to be here and hopefully talk to you about things that interest all of you as well. So the idea is to try to make it as non-lecture as possible. Like, we really tried hard to make it so that people have the opportunity to ask questions, so it's really interactive. Feel free to stop anytime, ask a question, because we don't want to be delivering a message. We want to be sharing a message and hopefully learning from each other as this evening goes on. So feel free to scooch up closer if you need to.
Thank you. And Chris, are you able to hear us okay? Okay. I wanted to just, if we could just raise our hands, I want to understand a little bit more about the room and who we have here. Can you raise your hand if you are a provider? Okay, so we have a few providers in the room. Okay. And then patients or family patient or members or patients. Okay. Thank you so much. All right, thank you. Yeah, I just wanted to see if the
balance. Yeah,
absolutely.
Okay. So
Okay.
we have lots of people that can also contribute to the conversation, and please refer to them for their expertise. So awesome.
Awesome. I was thinking that we could start with the basics of the brain and what I have three topics that I always like to cover in every single lecture I actually give. This is not a lecture today, but every single aspect of the brain requires nutrients. So these three concepts are extremely important because it has to do with how we're getting nutrients to the brain. Our brain requires essential nutrients to help us make our neurotransmitters, our happy endorphins, our serotonin, our dopamine. You probably hear these things often, right? Our fight or flight response neurotransmitters, things that help us relax and regulate and have cognition, right? And they're also essential for neurodevelopment, okay? So essential nutrients, when we think about these three things, we hear this all the time, right? We are what we eat, okay? So if we think about what do we have in our diet, do we have non-nutritive foods as a large part of our diet? Do we have a lot of processed foods in our diet? What are we eating? Are we eating proteins? Proteins are essential for the brain. They actually help us to make, again, our neurotransmitters. Proteins are the amino acids that help us to make our serotonin. So are we eating those things, right? Are we eating our fruits and vegetables? Are we eating fiber, things that help our digestive tract or our gut, which we're definitely going to talk a lot about today? we are what we don't eat, right? So a lot of our kiddos, a lot of the patients that we see, a lot of the people that we're seeing are selective eaters, right? And we're going to talk about why that is also. And a lot of times they aren't able, or they don't eat because they have a lot of sensory challenges around food, or even oral motor challenges, difficulty actually chewing or swallowing. And then of course the digestive issues that we're going to talk a lot about today, whether it's, it hurts, it medically hurts to actually eat, right? Or there's some sort of malabsorption that's going on in the digestive tract, like a celiac or Crohn's, or even just acid reflux, right? So we want to think about those things. So they might not be eating certain foods for that reason, right? Our fiber is very difficult to digest and break down. It could actually hurt, right? Or our proteins, we have to make a certain amount of acid to break down those things, okay? And then we think about most important in the kids that we're seeing, what are we actually using for fuel? So we can eat all the wonderful things, right? We can eat all the fruits and vegetables. We can eat all the proteins. But can our body use it, right? We need to be able to use it. Doesn't matter if we eat the whole salad bar. Can our body use it for our brain, okay? So these three things we like to consider in anyone, really, right? But specifically in our kids with neurodevelopmental disorders, right? And then going back to the essential nutrients, and we talk about other factors that can contribute to in selective eating. And I have these handouts for you too, just like as a guide as well. On the first page here, it says nutrition and autism and why it's so important. And I'm going to keep going back to essential nutrients because we have trillions of connections in the brain. We have billions of nerve cells. And while our brain is only 2% of our weight, our brain requires 25 to 30% of nutrients, right? From fuel and essential nutrients. And those essential nutrients are our proteins, our fats, okay? And our vitamins and minerals, okay? So it requires that. 60% of our brain is fat. So we need to have fat to fuel our brain. These are all essential. So when we think about why nutrition is so important for our brain, this is why. And when we think about why kids are, if kids are selective eating, well, first of all, where's that coming from? What's happening there? What's contributing to them not getting the nutrients that they need, right? So I always talk about nutritional psychiatry. That's my job, is to really look at the biochemical process that happens in our body. So when we think about the vitamins and minerals that we're talking about, right? They're required keys for every single process in the body, okay? And they work together. They don't work alone. So while you might have, folate, right? Folate requires B12. So we can't just give folate. And then to make serotonin, we think about our happy chemical and one of the most important neurotransmitters, right, is our serotonin, a happy endorphin. It's made, 90% of it is made in the lining of the intestine. 90%. So when we think about serotonin, if there's something going on in the gut, right, and 90% is made in the gut, right? If we have a chronic infection or a virus, right? If we have gene polymorphisms that are impacting that, right? If we have malabsorption, if we have a chronic immune system challenge, we are not making serotonin. And guess what helps us to make serotonin? Vitamin D. So when we see vitamin D a lot, right, low in the labs, which vitamin D is not stored in your blood, it's actually stored in other places, but when we see it low, we're not making serotonin. And we know that usually when vitamin D is low, that tells us, hey, there's probably something happening in the gut here, right? So vitamin D makes serotonin. And I have this little handout for you guys too, because I love talking about serotonin. I do.
Our happy juice.
Our happy juice. But if we don't have enough vitamin D, we cannot make serotonin. And guess what helps us to make melatonin, which helps us to fall asleep and stay asleep? Serotonin, right? And then all those little things in between are those essential nutrients. Those are keys. So those keys help us to make serotonin, right? We need those keys. They're essential. They're required. We have to get them from our food or supplementation. And our kiddos, our patients or people with autism require so much more than someone who has a more neurotypical profile. And that really does have to do with what we are digesting or using, right? And then talking about, like, as an RD, as a registered dietitian, a lot of times people are coming in because their kids are having a hard time eating. The variety isn't there. They're having a lot of different challenges with food. So I think about all of these things on this picture on the front page here, that we have different factors that affect them from eating. And when we can't eat, we can't get those essential nutrients in. So if we're having, learned experiences, this could even be if someone has had an adverse reaction with food previously, right? If they've had a chronic acid reflux or colic or chronic vomiting because they might have had a food allergy or something, right? Or an infection that impacts the ability for them to eat. And then they learn that as they're younger, right? And then they have an avoidance for certain foods because that learned experience, their body remembers that, right? It's like fight or flight. A lot of these kids are in fight or flight all the time. And when we're in fight or flight, we don't get into rest and digest. So we cannot digest our food. It hurts, it's uncomfortable, right? So we're like, yeah, let's just have all the fruits and the vegetables. But then, how are we going to eat those if we can't chew and swallow them, right? That really does start there. Is there any oral motor challenge? Do they have a tongue tie? Do they have a lip tie? All of these factors impact them eating. Never mind if we think about the core strength, right? A age-appropriate chair is very important for a child, right? They need to have their feet on the floor so that they can chew food. Think about if you're at a bar stool, right? And your feet are dangling. It's really hard to eat a steak. And you're like, let's just eat all this protein, right? And you're like, okay, well, we have a lot of sensory disturbances around lights and sounds, right? And then we have really low core strength, right? And we're swinging, and then you're like, just eat the steak. Eat the steak. and we don't understand why, right? But we forget about these things. What about the smells? Kids have a lot of challenges with smells and sights and sounds. So we want to think about all the things, right? And so these are all the reasons why we could have difficulty getting these essential nutrients in. It's not just about, okay, let's just eat this, right? Let's put this beautiful plate on the table. Let's just eat this, right? And then we get upset too. We're like, why can't you just eat the carrot? But also when we look at the food, right, it could be overwhelming. It could be too much to look at even, right? A lot of our kiddos like to eat the same foods over and over again, right? But that's because it's safe. They know exactly what to expect every time, right? When we think about the bland foods, the white foods, these salty foods, right? There's not a lot of taste there, right? They might be looking for salt. They might actually need that because they might be zinc deficient, right? We don't really get appropriate taste cues when we have zinc deficiency if they're chronically sick. We don't get the appropriate the cues to tell us exactly what something tastes like. You could taste a strawberry and it tastes sweet, but maybe your child, it tastes like dirt. Who knows? But we want to think about all of these things when we're talking about getting these essential nutrients in. I think if it's okay, if we just take a pause, I just kind of blurted out a lot of different things at once.
I just want to give a brain sort of corollary to what you've said.
Yes.
Because I think we underestimate how the gut impacts the brain. And I just ask each of you to think about a time when you've been nervous about something and you had butterflies in your stomach, or maybe you had to go to the bathroom, or maybe you were nauseous. Well, that's an instance where there wasn't enough serotonin to capture the moment, to get you through whatever you were trying to get through. Now imagine a child who has a chronic state of low serotonin. They're always looking for safeness, right? They're always looking for food to be predictable. They're looking for circumstances to be predictable. So I think if you can relate to that, you can probably understand a fraction of how a child feels when this is chronically happening every day, all the time. So I thought that's really helpful. Yes, all right. We'll take a break to ask some questions.
I was thinking, what do you
Yeah,
think?
I think that's a good idea.
Yeah?
Yeah, before we dig into some of the meat.
Feet on the floor for eating, because I've heard that before, and it just occurred to me, like at home we have my 6-year-old is very short in stature, so he still sits in like the stogie in a chair to eat, so his feet are supported. At school he has a special chair, but when we're out and about at a restaurant, I don't want to put him in a high chair because he's 6, right? Would it be better to have him like kneel, like, you know, or sit like cross-legged to kind of like have his like feet supported on the chair?
That would
Is
widen
it
his
okay?
base of support, and
Yeah.
that would give him, I would say.
I was just pointing at you, Sally.
Yeah.
I was like, that's a Sally
Kneeling
question.
as long as
Yeah.
as long as he's got his feet tucked underneath his bum,
Okay,
and if he sits crisscross applesauce,
yeah,
that's fine too. That's
Okay.
gonna give him that nice wide base to support, which will allow him to maintain his core.
okay, thank you.
Are you a physical therapist too? Occupational therapist, thank you. I apologize. I was like calling you out, but I was like, looking at you. I was like, I know this is a
Points to
question.
you every time.
Yeah.
Thank you.
My question. So when you were talking about the GI, obviously you know I had a bowel resection. Sam has had a bowel resection. So now obviously we're parenting a child, playing with behavioral things like that. So are our bodies struggling to find that serotonin to its even, because since we're missing those bowels, is it harder for us to even kind of find patients and things like that to even, like, are we already at a disadvantage because we have less bowel? Because it's creating less serotonin?
Yeah,
That makes sense.
yeah, I mean, you could, like, when we think about the lining of the intestinal wall, we have from our mouth all the way to our tush, we have this one, like, tube, right? And our 90% of our immune system is there, and our serotonin is there. So really, like, it's possible to still make serotonin in the lining of your intestine for sure. But in terms of an absorption standpoint, of course, with a bowel resection, there's going to be lack of absorption in certain parts of the intestine, right? Every part of our intestine actually has different nutrient requirements. Ava, would you mind grabbing that handout that I always talk about? Ava's one of our students. She's been so helpful, but I always talk about the intestinal permeability, which we're going to talk about today. But there's different parts of the intestine that require different nutrients, actually. But to answer your question, yes, when there's trauma to the tissue, we're going to have less absorption of all the nutrients for sure. And it's about supporting that. I don't know if I answered your question.
It's like hard.
You go first and then, yeah.
Oh, no, please.
Oh, I was just gonna follow up to say, is that similar to in the person who has Crohn's disease?
Or celiac disease. Mhm.
So I have Crohn's disease, so it's probably the same
Yes.
situation with malabsorption.
Mm-hmm. Yeah, now with Crohn's disease, depending on where the location is, but that has a lot of to do with iron for sure, and iron, yeah.
Mhm.
Okay.
And B12.
The other one, there's another intestine here.
But I think that's a
has the
good
nutrients.
segue as
This
we
is
talk about.
definitely
Wait, go
one of
ahead
them,
with your
which is
question.
great. I'm gonna put this on. Can you put these on one each table?
Like Dave, with the low serotonin. Can you talk a little more about what that looks like for children? Like,
So-
does it mean like they're more controlling because they want to feel safe?
So when you have low levels of neurotransmitters in general, it brings you into a fight-flight response all the time. You need serotonin to sleep. You need serotonin to relax. You need serotonin to absorb, food. And if you're not in that state, then you're constantly in a fight-flight, which looks like control. Like you want to be able to have the world be predictable as much as possible, and anything that seems foreign is going to feel unsafe to you. So food has to look the way that you want it to look. Mom has to be there when she needs to be there. I can't have strangers. I can't have you drive to the left when you're supposed to drive to the right. So we're really more controlling in those situations. So a lot of that rigidity you see is because of the lack of widespread neurotransmitters that allow you to adapt.
And I see that a lot.
Yes. Yes.
All right, thank you.
I know you had a question.
Oh, I was just kind of following up with her. Is the same, could the same be said for also ulcerative colitis as well?
Yeah, I was just
I
thinking
think it's
like
a good idea to talk about inflammation in general, and those are extremes of inflammation, right? I think what modern medicine has done poorly is we are very good at knowing what to do when you have Crohn's, when you have celiac, when you have ulcerative colitis. But what if you have all the stuff that's leading up to it and you don't have that yet, when your calprotectin isn't positive? Well, that's a lot of the kids that we take care of, is they have inflammation in their gut. And I think that's what we were going to talk about, the leaky gut, and pretty much what you specialize in, and how do we help strengthen that gut?
Yeah, so I created this. It looks really overwhelming, the handout, but I created it because I just think, and we'll go over every section of it, but I like it because it kind of explains a little bit of everything. But I want to, if it's okay, before we even start this, I know Ava knows, everything I draw, by the way, looks like a line and circles, everything. She knows that. I just like, so anyway, but I do want to talk about this term that we always hear called leaky gut, right? The medical term is intestinal permeability. But I want everyone to just like think really quickly about a flour sifter. Do we all know what a flour sifter looks like? Okay. It has these tiny little holes, okay? Very, very tiny holes in it, so that when you take the flour and you put it in the flour sifter, it goes into the bowl in smaller molecules, right? So it's like a larger piece of flour, right? And then it goes into the flour sifter into a smaller little molecule, right? And that goes into the bowl in the way that we want it, okay? Now picture your lining of your intestine like a flour sifter, okay? We want, and I'm going to talk about food first, but we want to be digesting our food. We're taking our food in, and it's in large molecules first, right? And we want it to go into our body in a small little molecule, right? Just like through our flour sifter, right? So we want to be able to chew our food, digest it, make certain amount of enzymes, and we want it to go into our body in the way that our body knows how to use it, in small molecules, okay? So let's just picture that flour sifter is broken, and now it has large holes into it. Now you put the flour into the flour sifter, and there's large holes, right? And now it goes into the bowl in a way that we don't want it. Right? Now our cake isn't going to come out right, okay? Well, this is the concept of when the gut is permeable, right, or leaky. So let's picture now like holes, not, in the lining of our intestine, right? Now when we chew our food, it's going in our body, and the body says, wait a second, what is this thing? Okay, it's now a large molecule that's not digested. So your body says, wait a second, this is an invader. A lot of times people will come in and say, I think I have a food sensitivity. And I said, well, it's not really about the food itself, okay? Because you're gonna have nothing left to eat if you just take all the food sensitivities that pop up in the test results, right? But it's the concept that my body is not breaking these down into smaller molecules that it knows how, right? That it knows this is food. It's like, oh, this is not self, right? Now that's just food, okay? But now what do we talk about with bacteria and viruses and environmental triggers? We're all exposed to these things, right? It's when these things are chronic, right? We only have a certain amount of things that we can handle at once, right? And we're all exposed to these things. But if we chronically have these insults, I like to call them insults because we're all exposed to the environment. I'm sure the allergies are crazy for some people, right? What is the threshold that we can handle, right? And so when we talk about, leaky gut and how that affects the brain, going back to that, right? If we have this large food particle that gets into our body in a way that's not supposed to be there, that directly causes neuroinflammation. And it's not just about the food. That's one part of it, and we'll talk a little bit more about that. But what about your viruses, your infections, right? All of those things can impact the way that our brain is getting those appropriate neurochemicals to do their job, to relax, to have cognition, to speak, right? To do all the things that we need to do. And so our job, or my job in the work that I do, is to find out why, what's contributing to all these things, right? And we look at number 1 here on this handout, this gut handout that I created. And these are just aspects of all the things that can contribute to this, right? So if we have the undigested food, which we talked about, now we can have food allergies as well, right? That would impact that. And then we also have intolerances, which are a little different, okay? I'm gonna speak about that for a second because you probably hear all the time, like, hey, like we wanna get the gluten and the dairy out. But that's the same concept that these are just very large food proteins, right? It's not every child, but most of the kids, I will say, have an issue with the gluten and the dairy. But they, even further than this concept, they can be making something called neuropeptides. Now these directly, this is page 2, I guess, food allergy versus sensitivity. So for the food intolerance, right, neuropeptide, casein, and gluten, they can cause an opioid-like response in the brain, okay? So that's when we produce like this drug-like response, okay, when gluten and dairy comes in. Now, this is not everyone, but it can cause true, like ataxia or dizziness, right? It can cause withdrawal, it can cause cravings. There are a lot of kids who have a really hard time, or people who have a really hard time getting dairy out. Those are typically people who have a hard time, or they might be making these neuropeptides. But essentially, the casein comes in, okay? The protein in dairy comes in, and the brain says, ooh, I love this. Just like drugs or alcohol or other things, right? It's like, oh, I love this. I'm going to remember this feeling because it actually does help to regulate the brain right away. It helps us to relax. It promotes this like, ooh, feel good feeling, right? With gluten and dairy. So right away, it's like, ooh, this feels good. I'm going to remember this feeling. And then eventually it says, well, I need more than just a little bit. I need a lot to produce more of that same opioid-like effect. Just like having a glass of wine. You have one glass, and then eventually you're like, I'd like another glass because this isn't doing it for me. And then your brain's like, oh, I need more than that. It remembers that because it actually does serve a purpose. I like to not, we want to think of regulation of the body serving a purpose. Like when a kid is having a tantrum, that's necessary. It actually helps the body relax, right? They need to do that. They need to get that stress out. That is the same thing that happens with food, okay? Now, when we talk about the difference between that and an allergy, this is delayed response. They could have gluten on Monday. It doesn't affect them until Thursday. It doesn't start to affect them until Thursday, which is why it's not just a little bit that we're taking out. You have to get it out completely if it's related to these two things, okay? There's no such thing as a little bit of gluten or a little bit of dairy in kids who have this going on. It just doesn't happen because they also will have withdrawal symptoms, right? They could be off balance because it can cause ataxia. They can have rashes, right? We'll see rashes in withdrawal because their body's like, okay, let's get this out, right? But then also, there are a lot of mood challenges with this. And so this is just one part. And then we talk about the food allergies, we have a wide range of food allergies. When we talk about like hypersensitivity, how it goes from like 1 to 5 on the allergy blood panels, right? You could have a small, mild allergy and it can cause some of these symptoms. They are not neuro-related though. There's a difference. The IgE does not cause neuro symptoms, but the IgG does. That's more neuro-related. And so here are some of the signs on there of the allergies, and then the food sensitivities. Again, those are delayed response. A lot of times, like, and I'm sure, you know, some of my families here can attest that, like, they're like, well, ever since we get the gluten out, or ever since we got this out, my child is doing so much better. And this is why, right? Today I had a patient that came in, and I only saw them once so far, and it's only been like 2 weeks, and she took out gluten was the first step, and her child was like spinning around a lot and just like running around the room, and she said that he's never been so relaxed, and it's only been 2 weeks just from that alone. I didn't do anything yet. We weren't ready to like do anything else but that, right? And that was a huge step, right? So something like that, 2 weeks, I mean, profound difference in just 2 weeks. And so these are some of the other signs that we see: nonstop talking, stimming, running around in circles. And then one thing that we do a nutrition-focused physical exam. So the hyperkeratosis pilaris, like the chicken-looking skin on that's usually related to like a gluten issue or essential fatty acids. But here are some of the symptoms of food sensitivity versus allergy.
Yeah, I definitely think about it in patients as a stimulant. So it acts like a stimulant. It stimulates the brain, the child feels good, but when it's gone, they crave it for a little bit. And then when it's completely out of your system, then they're back to their baseline. I think it's a hard thing for families to do, especially when they have very limited things that the child is already eating. So what do you recommend for that situation?
So I find that when you take it out, because you're helping to heal the lining of the intestine, right? Parents are usually very nervous to take it out first, but then they're able to eat more because now they don't have as much inflammation. So they're like, I really was so nervous to do it. I was nervous they were going to lose weight. And now they're eating everything. I'm like, yeah, because now we have more absorption and now it's not painful, right? So it's one thing, it's one step. It's not all the steps, but it is one. And that does help a lot. I love that question.
Fantastic. I always think about what stress does to your gut. And many of you have felt that feeling, right, in your stomach, where your stomach feels a little irritable. That means your body's making cortisol. So cortisol is a steroid. Have any of you ever needed to take a steroid? I'm sure you have. Steroids can be very irritating to the stomach. People get concerned about having ulcers. Now imagine your body is making cortisol, which is a steroid, and it's chronically making a steroid. Chronically, day, weeks, months, years of just having a little bit of a steroid that gets produced in your stomach lining. That really contributes a lot to this leakiness in the gut, and then food on top of it. So I think when you try to understand why kids get a leaky gut, it's because already they don't have enough serotonin, dopamine to keep themselves from being stressed. So they're stressed a lot, and that just hurts the gut even more. And the longer you're in pain, the longer you don't even appreciate that it hurts. So they can't tell you their belly hurts, even if they're verbal. And so that just really adds on to a lot of the stress. So I love that you're talking about how challenging it can be, but how rewarding if you can get to that place.
You brought up a good point about, I was thinking about how the dopamine receptors, right, with pain tolerance, I know that a lot of times we have a high threshold for pain, right? Because like if we are using dopamine very fast, then a lot of the kids can't really, if they're non-speaking also, some of the things that, you know, we wouldn't know if they can't tell us that it hurts, like if they're head banging or rubbing on their, you know, like their stomach or whatever, that can be a sign. But I was just curious a little bit more about that, or if you could talk to.
Yes,
talk a
so
little
the
bit about
more
that.
you are stimulating the dopamine receptor, the higher the threshold you have for pain. And so our kids can't tell us they're in pain because pain doesn't become a thing. Like I'm sure you've had, you know, family friends or your children, they'll bump into something and you expect him to be upset and he's not. And then his brother does something really silly and that really upsets them. So the pain threshold tends to be really, really high as a result of this whole process. And really, when you are stressed, when you're in fight or flight mode, your body's designed not to feel pain. So if you're in the war and someone shoots your leg, you're designed not to feel pain right there and then. You can feel it later, but it's really part of this whole fight-flight response.
Oh yeah, that makes sense. I know we talked a lot about like the foods. I was wondering if I just want to like talk a few more points about other things that could cause this. Did you? I'm sorry.
I wanted to mention because it is really hard to change their diets when they're so picky. Yes. But I will say for my son, so we took out dairy, gluten, some other things. But then we were just on vacation and it was impossible to keep doing it. And as the vacation went on, he was complaining about stomach aches. He was eating less and less. He was getting pickier. He was irritable when he didn't get his carbs and like dairy, basically gluten and dairy. And it was so obvious because he had been on such a strict diet. And then, I mean, it was just impossible to keep it, but it's like, it's worth it. It's worth it. You know, because he really, his appetite got better when he wasn't eating this. And these are things, this is like, was his whole diet, is basically dairy and yeah. And so, but I just want to say that it is worth the stress of doing the diet if this is an issue for them, because I saw it. It was just like, you know, and even he said, you know, he's like, my stomach is hurting all the time. You know, like he wants the food, but he could kind of start to see that like this wasn't really good for him, but he was still craving it.
Yeah.
Because we took about the gluten and dairy for Oliver, and my son really got eczema on his hands. We've found this for it's been like 2 weeks or something, and his hands are like tremendously bad just by doing that. And we've been to the dermatologist, and like crying because his hands hurt, and just doing that. And Aaron getting real with me and being like, "You need to do that," which is so hard. We were at the park the other day. The ice cream man comes by, which I hate the ice cream man now because nothing in there is everything is colored. So we took out dyes too as well. But I feel like your heart breaks for your kids because you can't give them what other
Yeah, I know.
what's best for them.
Yeah.
Even at the pharmacy today, he was getting something, and I'm like, "Does that have dye in it?" They're like, "Yeah." I'm like, why? Like, what is happening here? Can you order something else? So, you know, just even those things when you go to the pharmacy for stuff for your kids, I didn't even think about that. And that was like the last minute thing is, oh, does that have dye in it? They're like, oh, it does. We're gonna order you a new one. So just like stuff like that. But it is so worth it. Like it really is. And I'm gluten and dairy free too. So you kind of end up finding stuff. Trader Joe's has a lot of good stuff. It's really kind of shopping around. But it's so worth it. And it's hard though, like holidays and stuff like that. But it's worth it. And you know.
Every time I do it,
Put headphones on.
Yeah.
Just here's my nose canceling headphones.
I actually have a parent who gives the ice cream truck the ice cream that the kid can have. Like prior, I know. I was like, that is so smart. Like,
That is worth it.
White icy was a coconut icy. And I was like, okay, does that have milk in it? Because it was coconut cream. So it's clear, so it might be okay.
Yeah.
Milk in it. And I was like, I'm sorry. I'm sorry. Healthy ice cream trucks.
Absolutely.
So much better.
So we talked a lot about the food allergies and sensitivities, and then just to touch on a few other things, like there can be from chronic stress, we don't actually make enough digestive enzymes because that fight or flight shuts off, that fight or flight, that rest and digest shuts off. So we require something called digestive enzymes to break our foods down. We usually lose them as we get a little older, but when we're chronically stressed or there's trauma, even separate than, trauma that's going on from infections and virus and other things, we just don't make enough of those enzymes. And that's very important for us to break down our protein. So a lot of kids really have a hard time eating protein, right? And that a part of that is because we can't digest it. So it keeps going back to that. We're not making enough stomach acid to break that down. And so sometimes like something really simple that you can do is hum right before you eat. And that stimulates the vagus nerve. It helps the esophagus relax. And you can break, it can help to, make enzymes on your own to break it down. Gargling does the same thing, but that's really challenging for some kids. And then lack of stomach acid, we talked about that. And then also like the lack of stomach acid can also cause, or low iron can cause low stomach acid. And iron is something that comes up a lot because if a child is, on a really heavy dairy-free diet, the calcium actually can block absorption of the iron. So that's like one separate thing. But we do see that a lot in practice, that iron is super low. And iron is very important for B vitamins, which are also helpful for our nervous system. So we usually, most of my kids that come in, I right away put them on digestive enzymes so that it can just help them give a little bit of gut rest so they can break these food proteins down until we get moving on other things that we're working on. But also like infections and viruses, specifically candida and bacteria, can also deactivate those enzymes, and it also just breaks down the lining of the intestine. So a lot of the kiddos that I see have a lot of yeast, right? And yeast is going to impact us, using the nutrients for fuel too, which low iron is very common in yeast overgrowth as well. So we'll use digestive enzymes. We talked about the gluten and dairy-free diet. And then that also, like when we do these things, we start treating, those nutrients are going to start to come up. We're actually going to start to be able to absorb them now, right? So all the wonderful things that we are trying to eat, once we have, we heal up the lining of the intestine, now we're starting to get these nutrients, and that's why you start to see the progress in their kids. Go ahead. That is a really great question. There's so many factors. Like we're talking about yeast, we're talking about bacteria, we're talking about chronic stress, we're talking about genes that influence, those things. But if someone has a chronic infection or virus, it can take a really long time. Some of the kids that I see are on yeast protocols for years, and they just keep them on because the yeast is, listen, we all have yeast. We all have good and bad bacteria. It's when it becomes overgrown that it becomes a problem and an insult to the body if we can't keep it in check. So sometimes it can take a really long time. That is not like the most easy answer that I want to give you, but it is possible. I always say to parents, like, you're the expert of your child, not me. You get to see like, when they start to do better, and let that be your guide. Hey, like when I'm doing this is helping, right? We pulled the dairy and the gluten, the eczema's gone away, right? Regardless of what your doctor says, regardless if I'm saying, hey, I think her gut should be healed in a year, when you think about like all the symptoms that she was having before, kind of let that be your guide. And then also really testing is kind of the other way that we see that. We look at a lot of different things in labs and then also in stool testing to kind of see if the lining is, or the gut is starting to heal. Like we're looking at your digestion and absorption, the immunoglobulins, the rescuers, and then of course how she's feeling, neurologically.
Yeah, I wish it was as easy as 2 months or two weeks. It's so dependent on so many factors. In some kids, it's just a, digestive enzyme issue. In some kids, it's an overgrowth, undergrowth of certain bacteria. In some kids, there's leaky gut to the point that there's actually no nutrients, no B12, no iron, no vitamin D within the body. So it's sort of building blocks, and you're trying to figure out which part of those building blocks does the child need. And there are ways to test, and the most obvious way is to just look in the toilet and see what you see. And a good formed stool is going to look healthy. When it doesn't, there's something that still needs work. And you see the correlation. You feel better, the child feels better, the child sleeps better, the child's eating better, the child's gaining weight. And all of these are signs that we're heading in the right direction. Yeah.
I have a question kind of along those lines. It's about the gluten and dairy-free. Is there a test that you can give your child to know if you should pull those from their diet? Or are you suggesting that you do that for all children? Like, or if you see, I know.
It's a good question. We may have different answers, so you go first.
So I will test. I will test the blood. I always want to rule out celiac, but I will tell you, a lot of times celiac is negative in the blood. And I'm a perfect example. I always share, I talk about this all the time. talk about this in podcasts. I was diagnosed like 6 years ago, right? I had no GI symptoms, all neurological, anxiety, fatigue, depression, right? Cravings for carbs. But I had clear blood work, like did not have celiac in my blood. But my son came up positive when he was diagnosed with pandas, right? And that's how I got into all of this. But when he was positive in his blood for the genes, and he also had very low immunoglobulins, I was like, oh shoot, that's interesting. Who has celiac? And so I did the labs, negative, and then the endoscopy is what showed. So that is the gold standard in endoscopy, but it doesn't mean that you don't have, or your child doesn't have a gluten sensitivity, right? We talked a little bit about that. They don't have to have celiac, but they also can, which is why it's so tricky to look at the labs alone, right? And you could also look at food sensitivities, but then we're like going against this whole thing again, right? Because all the foods that you're currently eating are going to be positive because this leaky gut is happening, right? They're falsely positive. It's so funny because people come in for like with food sensitivity tests, and I'm like, yeah, everything that you're eating is positive. Well, yeah, but I'm not going to have you take out all your foods. You have nothing left to eat, right? It doesn't really. So I don't know if that. I know you probably have a different.
No, I think it's similar. I typically will test, and it separates the kids whom I'm going to at least talk about food and trying to remove what I know is a leaky gut, because not everyone has a leaky gut. And it's the kids with the pandas and all of that immunodeficiency phenotype. It's because they are inflamed. And so I say, listen, the child is inflamed. They don't have celiac disease. And the GI docs dislike me for that. There's one right there. Because they're like, well, that's not celiac. Why are you telling the child to stop eating this and stop eating that? They need to gain weight. Okay, I just like the brain more. So that's why I'm asking them to eliminate these things. But you had a question.
I'm the manager. I think he's from, I work with children with autism for 18 years now. And so many of the parents are always grappling with taking off of gluten and dairy, not taking off gluten and dairy. The children that I see the most positive response to gluten dairy removal are generally the children that have like cyclical regression, where now they're doing better, now they're doing worse. Now we have regression, and I think of those kids as having a lot of oxidative stress. And the oxidative stress is kind of causing all of those nerve cells to self-destruct. And so anything that we can take away that will lower this stress level, and particularly children with a profile where you're seeing slow processing speed, where they are accurate but slow thinkers. So they're coming to the right conclusion. They're often overwhelmed by the environment. It takes them a while to process what you're saying. And if that also goes with like the on and off regression cycles, those are the kids where we take them off gluten and dairy and we see them just check in, they're happier, they're more positive, and we see them becoming much more present. They're able to just take in the world better. They're more on the go. Typically, it takes about 3 months. So we're going to see that positive change right away within a week or two. But in order to start seeing movement where you start to see the nervous system repair, that can take as many as 3 months. So we'll see that positive change right away. Now the child's a little more checked in, but to start to see them actually learn better and development start to layer and move, that is around the 3-month mark. So I find that a lot of parents will give up and they'll say like, oh, I'm not seeing enough change. And it's like, you just didn't give it enough time. Like you're not seeing enough change because you did it last week. And we're not going to know whether or not this is sustaining and lasting unless we give it enough time for the nervous system to start to repair. Because the nervous system is not just going to change overnight. It needs to create healthier new pathways for you to start seeing the change hold and last. So for me, when I'm like, okay, which parent do I recommend the gluten and dairy? For sure, if their processing is slow and there's regression, those are the kiddos that I'm going to kind of earmark for that right away.
And it normally matches with this. It really
Yes,
does.
It
really does. Yeah.
doesn't it take like 3 weeks to get back out of your system, something like that, longer?
3 weeks to get out of your system.
Gluten. When you say you have it, it takes time to get out.
Yeah, I mean,
So that's why,
like removal, like
Yeah.
withdrawal,
Yeah.
withdrawal symptoms.
Yeah,
I'd
so
say
to
like
say
at
to
least
get-
3 weeks.
yeah, so like to me, it's like with your kids, and which is hard, it's like when you give it once, you're set back 3 weeks. So that's like always where it's kind of
Not
like,
necessarily. We think of them like little insults, right? It doesn't necessarily mean that they'll be backwards. I mean, if you're new to it, like, but I would say maybe you'll have more symptoms. But if you're far into it, because you're working on healing, the gut, then you shouldn't really have.
more forgiving.
Yeah, definitely. Because your immune system then starts to recognize, hey, like, okay, this is coming back in again. Like, I'm going to handle it, right? Plus, you've already done a lot of healing by that point. But early on, I could see why that, would happen.
I think she was next, and then you can be next.
So this is a little bit of it's on the topic of gluten and dairy elimination because, so we eliminated gluten and dairy because my son had horrible eczema when he was like 2. And we went to a nutritionist that dealt with autism and, he was diagnosed with autism at like 2.5, 3. So we did gluten and dairy free for like 2 years. The eczema cleared up right away. We also took out egg whites because that showed up. But we integrated the eggs back. Eczema didn't come back. And after a while, because he was so underweight and so like low on the growth spectrum, the pediatrician said, just like add it back, see what happens. And his autism is actually, he's very highly functioning and he's gotten a lot more, like he's actually improved even with the addition of the gluten and dairy back. We've seen the GI doctor, had an endoscopy, made sure he had no celiac, we have to do another stool test. But my question is, so if you've gone the gluten and dairy route and didn't see a huge difference, are there other nutritional things that you can do to support because right now the gluten and dairy does not seem to be changing his attitude. He seems to be at the same level he was, if not better than before. But we at this point are just like, we need to get as many calories into this child as we can to try to get his weight. And I think we're also seeing it. Endocrinologist, geneticist, like all across the board to see why he's so off the curve in the
Yeah, I guess my comment to that is not everything is for everybody. So I don't want people walking out of this room, yes, and saying that, gluten-free, dairy-free
Yeah.
for every child with autism. I love your comment because you've seen the phenotype of the child that seems to benefit the most. Some of the testing that we do helps to identify the kids that it could benefit the most, but it's not for everyone. And there's many kids I test and there's nothing. Gut looks solid. There's nothing wrong with your gut. There's other things, and we'll talk about some of the other things, right? You're not getting other nutrients in a different way. And so that's what I love about the diagram.
but not related
Correct.
to gluten and dairy.
Yeah.
Okay. Because I kind of have the same thing where with my Crohn's, I eliminated gluten and dairy. Certain gluten will handle fine, but other gluten within like an hour, my stomach goes out to there. So I don't see that with my son, but
Yeah. It's funny because I have families who will do gluten-free until they go to Italy, and then they're fine.
Yeah.
So,
Right.
yes.
Yeah.
Yeah.
Glyphosate and everything that they have here. Yeah.
Yeah.
I love that you mentioned that. I appreciate that actually, because there are a lot of kids. I mean, I don't necessarily always think that going back to this concept, it's not about the food itself always, right? That can be one factor, but then it could not be a factor at all, right? A lot of the testing that we uncover is yeast. I cannot stress that enough. Like the yeast in our kids is such a large factor. Histamines, right? Even from a genetic profile, issues with something called DAO or breaking down histamines, like they could have that in addition to the yeast, and that's what's causing these food proteins to be a problem, right? So separate than the food itself, we do uncover a lot of other issues that are separate and right, and it's like we don't see any benefit, and it's because we haven't treated those other things, right? So you could still see no benefit whatsoever because we haven't really addressed the stuff that's causing the gluten and the dairy to be a problem. I don't know if that
Yeah, I mean, the vitamin deficiency for
Yes.
sure. And so even for me, I want to explore that more. And another question I had about the leaky gut is like, because I saw on this handout that it could put you at more increased for autoimmune disease. My son was checked for Crohn's, doesn't show anything, but I didn't develop my Crohn's until
Right.
38.
Yeah.
So I'm wondering, my question on that was like, can it develop over time because you have not treated your leaky gut from a young age?
100%.
So that's why I am interested more in learning about the leaky gut and rather than the kids.
Absolutely. Yeah, I think this is a great segue as we
Yeah.
talk about specific nutrients
Mhm.
and nutrients that are really critical to, I'm obviously biased for the brain. I test for, iron deficiency, B12 deficiency, folate deficiency. I have to say that it's very rare for me to find a child who is folate deficient. I think probably like 1 in 1,000 kids is deficient in folate. It is probably the most important vitamin that our brain needs. And I think the U.S. recognizes it. They put it in our cereal. It's fortified, and as a pregnant woman, you're enforced to talk about folate. So they talk about it because they recognize it's really important in making an important chemical for the brain that is vital for making all of the neurotransmitters within our brain, including growth hormone and other hormones. So it is an important one. And I think there's been a lot of press talking about cerebral folate deficiency and how that can contribute to symptoms of autism, seizure disorders, difficulties with muscle tone. And there's many causes of cerebral folate deficiency. And really, we're not talking about dietary folate. We're talking about folate entering the brain and the brain being able to utilize folate to function, basically. I think parents ask a lot about MTHFR. I call the mother gene. Sometimes people will ask me, tell me about the mother gene and tell me about the connection with autism. It is poorly understood. And I think when you talk to a lot of your physicians, your pediatricians, they don't seem to want to talk about it too much because it's one of those voodoo type of things that nobody really understands. But I think the more we're understanding about this chemical, the more we recognize that it's not as simple as putting it in cereal. Your body needs to be able to take in that ingredient. It needs to be able to break it down. You need to be able to have the enzymes to break it down, and then your brain needs to uptake it. So there's a lot of places where it can go wrong, even if you present it on a plate to a child and they intake it. Children with autism have the lowest intake of folate in the US because chicken nuggets and fries have little to no iron or folate. So in general, these children are eating very little folate. And so it is one of the critical nutrients. When we talk about micronutrient supplementation, we talk about folate in some form as a supplement for children. When you think about this gene, this mother gene, I don't like to say the full term that people will use for this gene, it is responsible for breaking down folate or methylating folate in a form that the brain can then use. 1/3 of people have a mutation in this gene. So that means your gut is not getting enough of it. 1/3 of these children don't have the ability to break it down. And then there are other factors that need to now absorb it into the brain. And we're recognizing that about 70% of children on the spectrum have antibodies to the folate receptor that's going to uptake that folate. So think about it. I just want to repeat that 70% of children who get tested for a folate antibody are positive. So there's ways that you could go around it. Either you flood the child's brain with lots of folate, so 30% of it is going through the brain and they're able to get enough, or you try to get rid of these receptors somehow. Or give the folate in a way that doesn't need the receptor or this gene, is what we sometimes will do as well. So there are tests where we can try to figure out which children will respond to which type of folate, because we know it's a really critical part of making neurotransmitters in the brain. I want to pause because I know that some people have had more exposure to folate and the MTHFR gene than others, and want to see if any questions come up before we go into it a little further.
Do you have a test for the antibodies for the?
Yes.
Right behind you is the owner of the company. Actually, we're
Yes. So
Doctor.
religion.
they both, yeah,
Yes.
yeah,
You can check it up on that now.
yep, fratnow.com. Mm-hmm.
Yeah, I think we have some information in the corner people can pass around. There is a test
Okay,
that is
yeah.
available that you can check for the antibody. It's not required for you to test for the antibody, but it is helpful to be able to check for the antibody so that you're not giving the child over-the-counter folate, because that's not going to work if they have this antibody. You have to give one that would bypass the system. So it's been helpful for us to be able to get the test and see which children.
Yeah, oh yeah.
Absolutely.
Mhm.
So yes, go ahead.
Oh, sorry. Isn't the mother being hereditary? So
Yes.
like, the mother does not have it, then the children won't have it?
The father can give it to you too. So it comes from both parents.
You can have one copy or two.
Yes. You can have one copy or two. So a third of the people have an abnormality in one copy, another third have an abnormality in both copies, and then some people are completely normal. So testing the mother does not mean the child doesn't have it. Testing the father doesn't mean the child doesn't have it. What I think the worst combo, I want to call it the worst, the challenging combo is mother had it, right? Was taking folate that the child couldn't use. So child has been somewhat folate depleted during pregnancy, and then has antibodies to folate after birth, and that just compounds on compounds. So I think this is a topic you will hear more and more and more about. And I think even though it is slowly making its way into medical jargon, it has been highly resisted by many clinicians because it's in cereal. Why are we talking about folate? Everyone's getting it in cereal. Well, not everyone can absorb it the way that it's in a cereal form.
One thing though, I think we have to, I'm not sure if it, I don't know if this is clear or not too, but the folinic acid is what you're referring to. Folinic acid doesn't need a carrier to get inside the brain, but folate does, like
Correct.
methylfolate. There's a little bit of a difference, right? When we're giving leucovorin, which is the scriptose, that's
Folinic acid.
folinic
Bypasses.
acid. It's not methylfolate. It's not straight folic acid. So I just want to make sure that we're on the same page about that. But and that does require a script, right? And like Dr. Chetahambe was saying, is that over the counter too, like there is folinic acid. It's just not enough. There is like a folinic acid, but they don't make enough of it to actually be high enough in therapeutic dose, which is why we use it in leucovorin, which is also a chemo drug. Like they use it.
Scavenger saver drug.
Yeah.
Mhm.
Mhm.
And we'll talk a little bit about it, but why don't you go first and then you can go next.
I have two committee questions. If the mom has a mother, is that pretty much guaranteed it? Like, is it worth still doing the antibody test, or is that pretty much?
So the mother gene has nothing to do with the antibody.
Yeah.
So the mother gene means, okay, the child could have the mother gene, so let's give the child some methylfolate, right, to bypass this issue. But the brain will still need to uptake it using this receptor. And if the receptor has antibodies blocking it, then you're not going to be able to uptake it either. So then you're going to need the folinic acid, which is directly absorbed without need for the folate receptor.
So like the MTHFR is a different test. I'm a visual person. I like to see things. I don't know. I have a hard time with that. So I'm always, it's not, I always have to write things out, but also for people who are visual learners. The MTHFR is what Dr. Chetahambe is talking about. This has to do with the enzymes B12 and folate. This is folinic acid. So this is methylfolate, right? But with the frat testing, when she was saying antibodies are rescuers, right? So if let's say that folate is coming in. Let's just say that we're eating full broccoli, right? When folate's coming in, the body is sensing that it's a problem. The brain is sensing it's a problem. It tags it. So it's making rescuers, right? It's making antibodies. So it says that, oh, okay, this is a problem. I'm going to have to attack my brain cells, which is kind of what happens, right? So we need a different form of the folate, right? And it's in folinic acid. It doesn't require a carrier to get inside for the brain. Like, we don't need that. But this is a very different test than this. The MTHFR, which we mentioned, everyone, like a third of the population, could have a polymorphism. Not necessarily is it significant enough, but if you have two T's, which you was saying, right? T means trouble. So if there is a side from mom and you're right, dad, and if we have two T's, that means we have 70% more difficulty using folate for the brain. But that is still separate than this folate receptor autoantibody test. This is actually a different thing. It's not the same.
And then, so if you have the antibodies, but the methylated folate, not necessarily work.
No, it wouldn't. You still need folinic acid if you're making autoantibodies to folate, which I know is a little confusing. But
Yeah, I would
because
say the best
right?
way to explain it is that if you have a normal MTHFR and you're eating good amount of folic acid, and it's not folate, it may not enter the brain at the quantities you want if you're making these antibodies. So these two things, so you need folate to come in, folate to get in without being blocked by these two issues. So this one just means, are you getting enough? And then once you're getting enough, is your brain able to use it?
And then the other part is that casein, the protein in dairy, also blocks
The folate
this folate receptor. So on the testing that they offer, right, it looks at, actually, I'm trying to,
the binding,
the binding and the
blocking.
blocking antibodies. Yep. So they would have to take out casein also if you weren't already doing that.
Otherwise, it's falsely positive, but go ahead.
Makes sense for OBs to be doing this test as a pregnant woman to know if she's already, and then treat the baby or give, treat the mom and the baby.
Well, here's the thing too, right? Folic acid in the first 3 months is actually therapeutic. It's after that, right? Which I just think everyone should just take methylfolate and folinic acid. It's a very small amount, like over the counter, just so that we can not have that issue. But in the first 3 months, it's not a problem. But after that, we need to convert it, right? It has to be converted into methylfolate. But in these people who have these gene polymorphisms, it doesn't get converted, and then it actually damages the neural tube.
Yeah, so if they tested when they were pregnant, they knew that they had a mutation.
Well, I think testing is like, first of all, it can be expensive, right? And also, like, if you can we just need to change the prenatals, like give everyone.
Yes.
Everyone's.
You would think it was that simple. I think what they found is they did studies that showed that if you just flood the brain in those that have this gene and don't have this gene, the baby will get enough.
Okay.
So that was their logistics of saying, okay, as long as you flood enough of this, whether you have this gene or not, your baby should be fine. So that's the baseline logistics. And true, when you've done population studies, people who get neural tube defects and people who don't was completely improved by just supplementing folate. So that's why if you just told every woman to take a prenatal with folate, just regular folate, it made a big difference. Because the MTHFR gene does not mean you cannot methylate, it means you do it at a reduced rate. So you just need more volumes to be able to get enough to your infant. So I think when you talk about population studies, they do the cheapest thing for everybody and not the specific thing for one person.
Yeah, that's true.
Yeah, so really consider it. I work for providers as well, work for a rep, especially so it's so hard to be it's not one piece, everybody's different. It's been very so it's you have to think about there's so many different cases and you want not the best bang for your buck, but you want to treat as many people as you can.
Of course.
Not keep continuing on, okay, this baby had this thing cut off.
Well, it wouldn't, it also like isn't just the folate, right? There are insults that happen
Yeah.
in pregnancy, right? Like we are exposed to other things, infections and viruses and vaccines and all sorts of things that can, if we already have some sort of,
Insult.
insult, then it just exacerbates it. And then we require more folate and then the baby's not getting enough. So
And
to
then
her
you need
point,
B12 and you need iron.
right? Very
So-
complicated.
It is complicated. I think folate is an interesting one, but it still needs the B12. It still needs the iron to work optimally. But I know you've been burning, so I'll let you speak.
So who are the people that we want to do the FAT test for? If it's not only the people who have MTHFR, 1 or 2 copies, even people who don't have that can have
Yes.
the others. So
Yes.
who are we testing and when? And
Right.
why?
So
Why and why, but-
Yes, I think that it's a test that I offer to all of my patients who are having the symptoms of folate deficiency, which are
and
pretty much a lot of what the children I follow for, right? So I'm always looking at what can I do to improve the quality of life before I put you on risperidone, right? People that don't know that drug, that's great. You don't want to know it. So sleep problems, irritability, developmental delay, regression, poor muscle tone, poor movements, speech difficulties, vision, hearing loss, autistic features in general. So as we are trying to really help the developing brain, I do focus a lot on gut health, brain health at its core. And I think most families, when they come to see me when the babies are little, they're not wanting to talk about medication. They want to figure out what nutritional, natural things we can do. And so that's where we start. So a lot of these kids, I will offer the test right there and then to say, let's see if you are a candidate. I mean, the prescription folinic acid is called leucovorin. It is not available over the counter, so it is a prescription. It is not something that I just hand out to every child to say, hey, there's a high chance you have this. I'm just going to give you a prescription, because it can cause some irritability, hyperactivity in the brain. So it would be helpful to know which child to give it to, right? And so this test has been helpful. It's not 100% proof, but it's really kind of a helpful guide to know which child I'm going to push the dose beyond what I think is safe necessarily, because you have a high chance of having this folate deficiency in the brain. So it's a helpful tool when families can get the test done. Yes. With some experience.
Yeah.
Yes.
And I think I'm still a little confused by the results, even though you guys have both probably talked to me. I don't know, because he didn't come up like
Yes,
positive,
and
negative. It was the
soluble protein.
Yeah.
Yeah. So the soluble protein, I think we know that we're often looking at the receptor and seeing what's stuck to it or blocking it. That's what we're measuring. When we find that there is a soluble protein, it could be because there's a cross-reactivity with milk and dairy. So we say, you've been, obviously off of dairy for a while. It's probably that it is a mild case. It's in the making. They recommend testing it again in 6 months. Is that what your current recommendation is for the soluble protein? I think I have like 2 people who've had it.
Actually, there's increased cell turnover because of the inflammation. These cells of these folate receptors are floating in the blood. So they measure, this is a functional test, so it picks up everything. So this is one of the reasons. And it, like the doctor said, that it's also could be because of the milk formula, right? Overexcitement. So what we do is we treat it as a positive test and we test after 8 months.
I've seen that when I've seen in some kids that I've retested, because they have other inflammatory processes going on, like one of my kiddos that has Lyme, right? He was through the roof positive, right? And then we retested and it was normal, actually. But that was because we've really got the inflammation down. And, like we require, again, going back to, we just require so much more when we have a lot going on, just to remind ourselves of that concept that like we've treated the Lyme, we've treated his gut, we've treated all these things. So we require less folate also, right? But he was on the leucovorin, but it was, normal after the
Yeah, so I think we should
Retest.
probably retest because it is an odd result, but when it does happen, it's usually in the kid where there's inflammation galore anyway.
Mhm.
And so I'm like, there's more.
Yeah.
Yeah.
I don't know if you have anything else to add to like
It's
what
just
we
that
said or.
Inflammation is a lot of inflammation. This is not ACD. We have seen other inflammatory markers which kind of tend to go high, and there's a publication, there's some literature on it. There's some published work on that.
Okay. Thank you.
Yeah. And I've only seen it come back that way when the child is already set up for an inflammatory storm in general. And I kind of take a closer look in terms of the aggression with treatment in those kids. Yeah. Anybody else want to say something, ask anything?
I have one question.
Sure.
When you say that, I see this a lot with the slowing of the processing with gluten and dairy usually. What is the actual process of that? What is actually going on that's creating this slower processing?
Brain fog is what patients will say. So brain fog is usually a product of overstimulation. So people think it's tiredness, but it's really hyper alertness to the point that the child isn't resting and getting good quality sleep, right? So if you can imagine chronic, what's that drink called that kids like to drink? The Red Bull, the Red Bull.
Oh, Red
kids.
Bull.
Yes. So they're drinking lots of Red Bull to study at night, and they're not sleeping that well. And then they wake up and they're really groggy and they need to drink more Red Bull. That's kind of what that's creating. And when you withdraw from it, the thing that you feel, and I don't know if in this room there's people that have this gluten sensitivity, you eat a donut, instead of feeling energetic, you feel foggy. Like I can't think, I can't focus, I can't do all of these things. And you would think I just got energy. Well, it's the complete opposite. So when you withdraw from it, all of a sudden your brain starts to become clear, you're focused, you're able to, and it's really that inflammatory that tags onto all of the sheath on the nerves basically and causes inflammation and flow of electricity to slow down. Yeah.
So when an autistic child doesn't sleep and they're up in the middle of the night and they're like bouncing, they're, hyper, is that because of this or, and what can you do to help them?
It could be because of this and many other things, right? So steroids, any of people who've taken steroids can attest to this. Okay, so you know that you bounce from one wall to the other, right? So a child who's chronically got cortisol in their system, which is a steroid, doesn't have the ability to rest and sleep. Like they are constantly in a high alert state. So they sleep with one eye open and don't get into that nice deep REM. And it's all of that. So what you're trying to do is to try to reduce inflammation. This is a strategy by eliminating folate, not folate, gluten and dairy. You're reducing that cortisol surge, basically. And for the child, it could be other things besides that, but that's part of it.
And how would you
Yeast.
tell?
So it's such a packed question, I feel, because we're talking about many things, many insults, right? So what is happening? We have to figure out what's happening first. Like, is there dysbiosis, which means an imbalance of good and bad bacteria? We've been talking a lot about like removing things, and we forget that we also need to add the good things in too, right? Our good bacteria, we need probiotic rich foods. We need prebiotic rich foods that feed the good bacteria so that we have a healthy balance, right? When we are chronically sick, our bad bacteria is a little higher, right? So we do need to balance that out by adding in good. And the reason why I'm mentioning that is because we obviously, figure out what's going on, but we also, while we're doing that, we need to try as much as we can to add in other things that help support that neuroinflammation. We talk a lot about removal, but we really need to add things in too to support our nervous system. And that is, again, going back to the essential nutrients, that they're being lost by things that are happening that are causing the inflammation, like, the bacteria, their yeast or genetic whatever, the food proteins, all of these things.
And there's testing for all of that.
Tons of testing. There's always a test. There's stool tests, there's urine tests, there's hair mineral tests. There's all sorts of things to actually look at what's going on. And then we kind of just, go from there. But the plus minus, we need to add good things in too, right? To support our good bacteria for our nervous system. And it's never just one thing. I wish it would be, right? It'd be so simple. None of us would have a job if it was just one thing. But yeah, it's complex.
Thank you. So, this is back to the Lauren question. You guys are up front here. In a conversation with Dr. Fry mentioned, and he published a study on leucovorin, and he mentioned that he has seen many children who come back with the negative frat and yet do really well on the leucovorin. And that was a little confusing to me, because then it's like, so is our protocol to say, we do the frat test, if it's positive, you're a candidate, or is it you have autism, you check off these symptoms, you're somebody we want to try leucovorin on, do a little trial and error, see how it goes. Nothing against the test. I'm not trying to demote the testing. So it was just a little confusing to me to hear that. And I also wonder then, are there a number of different factors that influence how the brain is taking in this nutrient?
Yeah.
And are some of those factors not accounted for in the testing?
Yeah. There's a lot of layers to that.
Yes, a lot of layers. I think, I don't know if we have specificity and sensitivity data on the FRAT test.
Yeah, so the specificity of protein in the late 90s, it's 97.6. The reason why the folate works, it's typically around 5 milligrams or 2 to 5 milligrams. You don't give that high dose of 25 milligrams, but you use it to simple. Because folate is important in many pathways, just not only just the solving the cerebral folate deficiency. It improves mitochondrial function. It's important for a group cell production. So the antioxidant pathway gets activated. Low folate means high homocysteine. High homocysteine means low growth time. So folate is very critical. That methyl group has to be picked up by B12 and converts homocysteine into methyl. So high homocysteine is also toxic. We know that.
Yeah.
High homocysteine also acts on the NMDA receptor and acts as a glutamate agonist.
Yeah.
So there are a lot of and also I think Dr. Charahambe touched on that point about serotonin, right? Now, folinic acid gives rise to something called guanine triphosphate. This guanine triphosphate gives rise to something called BH4. Now, BH4 is actually a drug. It used to be a supplement 30 years ago. It is a drug which costs around $50,000 a year. It's nothing, it's a treatment for a condition called phenylketonuria. This BH4 is also the cofactor for conversion of tryptophan into serotonin and tyrosine into dopamine. Now, if you have low folate, it's all affecting that. So a little bit here and there. I think there are a lot of other functions of folate. That's why, especially if you reduce oxidative stress, you will definitely have improvement. So that's why
So can we say then that all children with autism or depression can benefit from low dose, but whether to decide if you want to give high dose, that would be a frat positive. So frat positive kids should get 10 milligrams twice a day, but all children can experiment with 2.5 or 5.
Yeah, that is what I practice pretty much that. Like I am very nervous to aggressively push it because I have seen agitation and worsening. It is not pretty. Yes, exactly. So it is not something you just want to do. And I feel like there are practitioners that are just like, here's 25 BID, go home, try it out. I'm a little nervous about that. I would prefer to do it because a little bit is good for everybody. Too much is not good for everybody. Some people do better than others. So I think that's where it's helpful. And I do have parents who, and you know one of them, who wonderful effects. Like my child is engaged, more social, double it, please.
And eating.
Yes, and eating.
Yeah.
Like not eating, like
Not eating, no appetite, either you want cheese and eating like 5 calories a day, and then leucovorin, and then instead of sitting down on a meal.
exactly. Constipation's gone, everything is gone, and mom's like, "Can I double it?" I'm like, "Hold your horses."
Yeah, I know. Right. I mean, sometimes too, they'll have a little bit of agitation, but we sort of wait it out a little bit. I'll add like some magnesium to sort of help settle that in. And then we'll just wait a little bit longer, even starting on a low dose. And sometimes, because they could be so deficient, it's very hard and just like forget the testing for a second. If folate is really, really low, it's gonna, it's gonna be very activating for the brain. So we have to expect that a little bit. And that doesn't mean that there's a problem. It just means that we need to go a little bit longer, slower, and just add some other things to support the nervous system. And it could be beneficial for them.
Yeah, and when the PrAD is positive, I work through it with families because families will quickly say, "I can't do this anymore." But if it's positive, it's helpful to kind of help them through and help them recognize, because the first sign would be like, "I'm not going to do this."
Yeah.
So it is helpful.
Yeah.
Yeah, one more thing I think is right. I prefer having a low dose and titrating it up rather than going full on going down. I mean, as I said, parents before, folate doesn't get absorbed beyond 25 milligrams. The maximum dose which can be absorbed is 25 milligrams of folate. After that, the transporter gets saturated.
Yeah.
So you're really putting 25 milligrams and taking like nothing. So 25 is the maximum.
And what weight is that for, the 25?
Excuse me.
What weight approximately? Like a,
The weight has to be at least, any weight. It's the maximum capacity for the proton coupled folate transporter is 25 milligrams. That's what all the.
that's interesting. Okay.
Right. Dr. Fry says like 0.5
50
milligrams is
up to
starting
25.
up to max 50 milligrams. I've
25
also
CID.
spoken to him at the last conference or one of the conferences that we were at, and he does all the research. And he said 5 milligrams has been like there wasn't, a lot of his patients, and even in the research, he really has said that it's kind of like works similarly to the higher doses.
Yeah.
So I don't know. I just think, again, when we talk about individualized care, we just need to look at how they're functioning and what, so.
Yeah. I mean, it's one of those treatments that when you start it and it helps, it's not subtle. Like you're not guessing. You're not like, did it help? Did it not help?
Yeah.
It's like everyone around the child notices something is different about the child. And so it's a rewarding experience when you have a child who responds, but it doesn't happen to everybody.
Yes. Are a lot of these things also on the same page for kids with ADHD?
Yes. Anxiety, depression, even schizophrenia.
Yeah.
Mhm.
So you also treat kids that
Yep.
have ADHD?
Oh, absolutely. Absolutely. Yeah. Neurabilities. And we have some information out there if anybody wants to pick someone. So we have an office. We have an office in Wall Township, in Cherry Hill, local. Yeah, absolutely.
What other questions do we have?
Do you feel like the PANS panda kind of comes out a little bit more when they have these deficiencies? Because I've experienced that with my daughter, like after illness, like severe like OCD, what I think is probably PANS panda and whatnot. Do you feel like it is like usually,
It's there's so many layers because we have to figure out, well, what are the triggers? And in PANS and pandas, there's an underlying autoimmune issue in the right. So we're not making enough rescuers really to tag things. So anything that comes in is a problem. Whether it's the kid that's next to them that they catch strep, or they have mycoplasma, or they have yeast, or they have food allergies. They're really super sensitive because their immune system is just not working well.
Sorry.
Yeah, so
It's a
sorry about that.
pediatric.
Pediatric acute neuropsychiatric syndrome is PANS, which can be Lyme's disease, co-infections, mycoplasma, all sorts of different things that affect the neurochemistry. So we used to think that it would be more of an acute onset, and that can be, like overnight. We see a child is, having severe anxiety, OCD symptoms, restrictive eating. That can happen overnight, but now we know that it doesn't necessarily happen overnight. It can be like
Weeks or months.
weeks or months. And
it's more
usually,
subacute.
yeah, usually like after an infection or a virus, but there's so many other layers to that. And then PANDAS is more specific to strep, so pediatric acute neuropsychiatric syndrome associated with streptococcal infections. So that's usually, that also can be an acute onset or weeks, or months later after a strep infection. And these kids typically have higher amounts of strep. And strep, I think this is very important because I talk about it all the time, and strep does not have to just live in your throat, right? So a lot of kids are asymptomatic from a throat perspective, but when we have autoimmunity, that means our body mistakenly attacks its own tissue. So for these kids, it's mistakenly attacking healthy neural tissue.
Right.
So the strep comes in, and it's called molecular mimicry, but it's attacking the neural tissue instead, right? So we don't have to have, symptoms like throat symptoms. It can actually live in the GI tract. It can live, we talk about, what is it? Rheumatoid, not,
Scarlet.
scarlet fever, rheumatic fever, right? The joints, right?
The genitals.
Everywhere. So sometimes kids are testing negative, for throat culture with these symptoms, but it can be anywhere. So we just be really careful. I always mention that because I'll tell my patients, they all know, go get a strep culture. But just because it's not there does not mean it, like in the strep culture, doesn't mean it's in, sometimes we'll see the red ring around the anus, right? That's strep. Or, the chapped lips, like the smacking of the lips, it's very, very chapped, that's strep. The peteche at the top of the mouth, that's strep. But there's so many other places that we see it. So
It's a specific clinical profile, though. But go
Mhm.
ahead.
Just came back as 112 the other day, and so I brought him to do the culture. His throat was negative. So
Yeah.
then you're like, and we're going through all these other things, but we're just like, what is happening? And it's not in the throat. His throat's fine, and but it's so easy. You guys understand it when we go to my regular pediatrician.
Yes.
He said to me the other day, he said, "This is more of a theory," and this is why we get so lost
Mhm.
because
Yeah, it's very frustrating.
people
Yeah.
are like, oh, well, we treat it this way or that way, or it doesn't really exist, it's not real. And you're like, what do you mean? Like, I'm confused because this is real. There's so many people who are struggling with these things. Why is my kid strep off the charts? Why are X, Y, and Z? And then, like you said, the Medicaid, things like that. It's just not, and it's hard to get, that help when you're struggling with the kids having, behavioral things
Yeah.
like that. And it's hard to find people like help in those situations because a lot of people don't understand.
Yes, there's a lot of controversy, as you
Yeah.
know. It's sort of similarly with the Lyme and the Bartonella. There's a lot of controversies in our medical community about it. I will say that it's less controversial when it presents as the clinical profile of subacute, weeks to months of severe onset OCD, usually with some facial tics, and associated regression in the development. I would say that most of us wouldn't disagree on that. And then you have the titers, the blood work shows really high levels of strep, approaching 1,000. And then there's not a lot of pushback on how you would treat it. I do find when families come in and the levels are in the 200s, 300s, there really isn't a clinically distinct change in the behavior or a time point where a change has occurred. It's really hard to then go and swab anything because it's been there low level, low grade for too long. And so trying to then use the immunotherapies can be difficult in those situations. And you want to try to find something that's more chronic. But the signature of that blood work tells me there's something autoimmune in that child. And so our approach is to approach them as an autoimmune child. But yeah, I think that's the best way to kind of summarize where our community is right now in terms of having our pediatricians be willing to test. I beg pediatricians, just do it, please, just do it. And when they do, they're like, it was strep negative, but the culture came back, and then they tell me what it was. I'm like, put the child on some antibiotics, tell me what happens. Child is better. Okay, then it's solved.
Right.
Definitely to be higher, because I know the lab work said 112 was high compared to what it was reference range was 0 to 70 or something. So much higher it needs to be for that.
But there's anti-DNase and then there's a strep titer, ASO titer. So there's a difference. But like typically when and we look at trends too, and also like clinical symptoms. But he could have had a strep infection ages ago, and the titers are still a little elevated, right? Doesn't necessarily mean that your child is pandas. We're really, it is a clinical diagnosis. But we'll, sometimes I know that sometimes we'll check and just to kind of keep an eye on that. But really, if you put them on antibiotics and they do better, and then you take them off antibiotics and things change, I know like that's a good sign that there's probably something. But like you said, we're treating them like an autoimmune, child, because it's not just going to be strep if that happens. There's going to be other things, not just strep. There's going to be that we're not even testing for. Okay. But it is one little thing.
One little piece, exactly. Go ahead.
This is a question for her, and maybe for both of you. I work with so many children that have recurrent strep. So they will have strep 5 times a year.
No problem.
They get better. They're better for a couple of weeks. Strep comes back. And I have children who've been on 5 rounds of antibiotics in 3 months or 4 months. What is a preventative or what is a supportive treatment to keep the strep from coming back? So that we're not doing this cycle over and over and over again.
Right. Now, I use a lot of herbals in practice in conjunction with the antibiotics, or prophylactically. Some of the physicians I will work with will just give antibiotics long term, actually, to keep it down. But I find that the kids that I see that are on herbs alone do really well. Sometimes it is an antibiotic resistance, or there could be other things that we're not looking at that are keeping the strep up. Remember, we have good and bad bacteria, and just because strep is overgrown does not mean that that's the only bacteria that we have going on, right? So you could try to treat strep, but it might not just be strep. There might be other types of bacteria that are also necessary to be looking at, right? So you could be, we could be using this antibiotic for the strep, but there could be other things that also need to be treated, which is why I like to use herbals, because they kind of work like a broad spectrum. They can treat other things, and they're also immunosupportive. So they help to support the immune system at the same time. Whereas antibiotics, most of them don't support that. You're wiping out all your good guys. So we really need, it's hard because like if you're not using the right probiotic, away from the antibiotic at the same time, then and the immune system is not working well, then you're going to keep having a challenge with the strep. And I don't know what your thoughts.
I would say that's an immunodeficiency until proven otherwise. Like there's something wrong with your immune system. You should not get strep multiple times. And we saw after the pandemic, there was a big strep, so we know that there was dysregulation that occurred during COVID, either from the infection itself that caused immunodeficiency in a lot of children. Children had infections with strep that we had not seen since the 1900s. In their sinuses, in their brain, that is not normal. So you should not, as an adult sitting here with the child who has strep, get strep. It's not normal. If you are getting strep 5 times recurrently, you have an immunodeficiency.
And you just brought up a good point, because we forget that there could be an asymptomatic carrier in your house, right? A lot of times I'll make the whole family do testings. I'm like, I'm sorry, but your kid keeps getting strep. I want everyone to get tested. And sure enough, the parents, and we've had a few mutual patients that's happened, right? Where the parent is the strep carrier, no symptoms, and they just keep giving it back and forth to each other, right? So that we have to treat the whole family.
That child is like everything is just
Stuck to them.
Immune challenges.
Are there specific herbals that are very dependent on?
It's very dependent on the person for sure.
Throw out these 3 are great.
I will give you one idea, because I know it's safe for most people, but it has black walnut in it. Biocidin, I use it all the time. I use it for a lot of things. Biocidin. But you really have to work with someone who knows how to use it, because it's also a biofilm disruptor. So if there's other things going on, right? So biofilm means like if you have antibiotic resistance, then and it's like hard to treat, right? But once you if you have if your child has a biofilm, right, and you go in with a biofilm disruptor, we're opening up other things that we might not have known that were there. So if you don't work with an experienced provider to be able to like deal with all that other stuff, so that's why I'm not like, I don't love giving recommendations like that out, but I will tell you if you want to research it and use it with your provider, it is something that we use a lot.
Yes, for that patient that you're thinking of, could the diet be the part of the problem? Like if they're having constant gluten and dairy with the inflammation and their immune system is busy working on that, those particles, maybe that's what looks like their immune system's so low and they're getting everything on top of that. But I always see like my immune system's busy when I have gluten and dairy, and then I'll start getting run down quickly, and I get a cold. And then if I take it out, I'm pretty good for a month. And then I'm not, you know.
Yeah, so it could be a lot of things. I had in one family, they had mold in the house. And we kept treating the strep. It had nothing to do with the chronic mold makes your steroids high in your body because you have an elevation, and so you're immunodeficient. So you're constantly getting sick. So there's so many things to think about, and I think sometimes we're just focused on the thing the child comes in with. But when something is happening repeatedly, we need to step back and think about the family members, think about the environment. Something else is going on.
And that's why we have all this wonderful testing, right? I don't like to guess because there's so many different things. Of course, like dietary wise, there's a lot of wonderful first steps that you can make, right? But if there's a lot of chronic things going on, we like to take a peek and see what's actually happening, right? So a few more questions.
I just want to say, I think it's because we have providers like you guys who give us
Thank
real
you.
information. We really listen to us parents and go through these steps because, like, as you know, and I know, I even told my pediatrician about NPHFR, and she said, "Oh, that's just, don't even worry about it, that's nothing." And I was like, "Really?" But you know, thank goodness we have people like you guys to listen and do know this stuff.
Thank you.
Of course, thank you. Thank you.
Thank you.
Voldy, you had your hand up too.
Oh, yeah.
I have to say that when I see kids every day, there are no two kids that look alike. And so it really is hard for me to say, go home, give your child this, because that's what worked on this child. Every child is so unique, and I like to really personalize and individualize, and I love that you do the same. I love that you do the same because it really helps for us to try to make sure that we're giving the right thing to the right people, because
That's what the whole medical profession should be doing. I mean, none of us are this.
I went to school and everything I've learned has been since school. So
Yes.
my patients have taught
Oh.
me this. Because I will tell you, not one day did we have a talk on MTHFR, not one day. So all of these things that we're talking about, my patients taught it to me because they come in and they have symptoms and I'm like, this isn't in the textbook, wait a minute. And then I see another one, I'm like, wait a minute, that wasn't, and then they match. And I'm like, oh, that connects with this child. And you start to make those connections, but it was all outside of being in the classroom.
Yeah.
Yeah.
Yes. When we go together, I went to me one night with the blood cavities that we because there's something they're saying.
Yeah, there is, but I can give you my information and you can definitely email me. Yeah.
I do want to mention really quickly, before I know that some people are going and I'm happy to, we have like some snacks and refreshments.
Please have
and
some.
stuff. Please don't, please. Zia, one of our dietitians here, who's also a chef, like cut them all so nicely and everything for you guys. So even if you want to take some home, that's great too. And I know that Doctor, you guys brought some cupcakes too that are gluten and dairy free. I think they're in the fridge though. I put them in the fridge because they were, so definitely take stuff home if you want. But I wanted to mention, because I know some people are trickling out, I wrote it on the other side, that all of our information is over there, right, for you guys to take. And our practice, Root Health, Nutrition, and Wellness, we have like a voucher for like $150 coupon or whatever for any of our services. So like if you choose to do a membership or you want a specialized test, or we also offer hyperbaric oxygen therapy here. We have that as well. So you can use that for any of the services, so that we do have a little coupon over there for you. And I just wanted to mention our next workshop is actually just a meal planning workshop. Zia, who our chef, is going to be doing that. And that is June something, sorry.
Let's make sure.
We'll probably have one. We have one before that, but just check the website. I just don't remember what it is, to be honest. But June 4th, a meal prep workshop at 5:30. We definitely will have that. It will be on the website. But I just wanted to make sure, because I know some people are trickling out, that I mentioned that to you. Yeah.
What is your basic protocol for the testing?
For the testing, so I don't have any like protocols, but for testing, usually I'll do a comprehensive stool test, and then a urine organic acid test at the same time.
Yeah. Well, thank you. No, really, this is mind-blowing.
So yeah, so the stool test will look at digestion and absorption.
Hey.
So like, how are we breaking down our carbs, our proteins, our
Okay,
fat?
great. Yes, and I
Do
work
we
very
have
closely
enough
with-
digestive enzymes? Is there inflammation?
We matched the stations.
So look at that, and then it looks at the good bacteria, the bad bacteria. It looks
how
at
did you
yeast.
find
It
it?
looks at parasites. It looks at any infection, H. pylori. It looks at all of that in the stool, and then the urine test breaks down the neurotransmitters. So serotonin, dopamine, fight or flight response neurotransmitters. It looks at yeast, bacteria, mold markers, and then some nutritional markers. And lastly, it looks at the mitochondria. So how are we using nutrients for our brain? It's very comprehensive.